A 62 year a 62-year-old man with large non-Hodgkin lymphoma is brought to the emergency department because of 3-day history of fatigue, dizziness, and facial flushing that is exacerbated by bending forward. His only medication is omeprazole. On arrival, he appears slightly cyanotic. His temperature is 37 degrees Celsius, pulse 96 per minute, respiration 20 per minute, blood pressure 140 by 90. Examination shows brown edema of the neck and face. The veins of the anterior chest and the shoulders have been dilated. Breath sounds are normal, heart sounds are distended. A CT scan of the chest, clear progression. CT scan of the chest show clear progression in size and distribution of the mediastinal and the abdominal lymphadenopathy. The inferior vena cava is posteriorly displaced. IV hydrocortisone therapy is started. Which of the following is the next step?
Ready?
Yes.
It is radiation therapy. SVC syndrome, superior vena cava syndrome, is a rare condition that occurs due to compression of the superior vena cava. Common causes include cancer, blood clots, inflammation. Symptoms of SVC syndrome include swelling of the face, neck, arm, shortness of breath, coughing, hoarseness, and difficulty swallowing. In severe cases, the patient may experience cyanosis, confusion, loss of consciousness. Diagnosis of SVCS is made through a combination of physical exam, CT, and MRI, or MRI and lab studies. Treatment is dependent on the cause of the SVCS. In this patient who has begun to receive IV steroids, it's appropriate to begin radiation therapy to shrink the size of the mass to alleviate compression and restore normal venous flow. The prognosis of this condition depends on the cause. Malignant invasion or compression often carries a poor prognosis. It's not a thoracotomy, it's a surgical procedure that involves making an incision in the chest wall to access the thoracic cavity. Thoracotomy is performed in the treatment of intrathoracic pathology, including lung cancer, pneumothorax, hemorrhage, and congenital defects. Okay, next. Oops.
A 42-year-old woman comes to the physician right heel because of increasingly severe right heel pain since she stepped off balance onto the foot 4 weeks ago. The pain increases with weight bearing and decreases with rest. She has asymptomatic SLA and chronic renal failure. She receives hemodialysis. Her only medication is hydroxychloroquine. Vital signs are within normal limits. The skin over the lower extremities is intact. Dorsalis pedis pulses are 1 plus bilaterally. The posterior tuberosity of the right calcaneus is tended to palpation. Motor examination showing no abnormality. There is space planus bilaterally. Sensation to the light touch is intact. Lower examination of the right examination. Which of the following serum studies are most likely to show increased concentration of which of the following? Ready?
One moment.
Sorry?
One moment, please.
Yes, yes.
Mhm. Activate. Increase concentration. Uh, Let me see. I don't see anything on the pectoral. Calcitonin calms the calcium, tones the calcium down. Definitely have low calcium. If the calcium is low, then PTH will be high, I guess. Doesn't make much sense, but okay. Ready. So it's PTH. CKD can develop as a result of variety of mechanisms. Mm, yeah, general management includes blood pressure control, restriction of fluids and protein, smoking cessation, bicarb supplementation from metabolic acidosis, treatment of contributing disease, and hemodialysis in end stage. CKD can be complicated by hyperkalemia, volume overload, metabolic acidosis, anemia, hyperphosphatemia, hyperthyroidism, hyperparathyroidism with subsequent changes in bone structure, such as renal osteodystrophy. Hypocalcemia and hyperphosphatemia can lead to hyperparathyroidism as the injured kidney is unable to appropriately absorb calcium and secrete phosphate, causing the parathyroid to increase its hormone production. Many patients require phosphate binders, such as sevelamer, when undergoing hemodialysis for this reason. In this case, the patient requires hemodialysis with X-ray of the ankle showing decreased bone mineralization or cortical irregularity in the posterior calcaneus, indicating signs of renal osteodystrophy. They're most likely to have an increased concentration. She's most likely to have an increased concentration of serum PTH in response to electrolyte abnormalities secondary to end stage. It's not 125 vitamin D, and which is calcitriol, and 25 vitamin D. 25 vitamin D is activated to 125 vitamin D in the proximal convoluted tubule by the enzyme 125 1 alpha hydroxylase. In cases of end-stage disease, the kidney has reduced ability to activate 25 vitamin D, which contributes to lower concentration of calcium seen in this patient population. PTH is more likely to be increased in this patient secondary to decreased calcium and increased phosphorus water. Okay, so why is it not C?
25
Oh,
hydroxyvitamin D.
because if it has less, it cannot activate 25 to 125, then 25 will be high. Okay, I guess they don't.
Usually this marker for CKD 25 hydroxyvitamin D is not seen. For CKD, we actually see there is hypocalcemia, increased phosphate. Inorganic phosphate is also done. Inorganic phosphate is high too because kidney cannot excrete the high phosphate, and PTH would be high secondary hyperparathyroidism.
Next.
And your question is valid,
Mhm,
but usually for CKD, these markers are usually seen.
mhm.
Okay, ready?
Yeah.
72-year-old woman comes to the physician for a routine follow-up examination. She has type 2 diabetes, mellitus, hypertension, CKD, osteoarthritis of the knee. She says that she feels well except for mild swelling of her feet, which has made her shoes feel tighter. Her medications are lisinopril, naproxen, acetaminophen, metformin. She is 176. centimeter. She is 170 centimeter tall. Weight is 81 kg. BMI 28 kg per meter square. He has gained 2.3 kg since her last examination 1 month ago. Her temperature is 36.8, pulse 72 per minute, respiration 16 per minute, blood pressure is 112 by 62 millimeter mercury. Cardiopulmonary examination shows no abnormality. There is 1 plus pitting edema of the ankles. Her hemoglobin A1C 6.1%. Serum creatinine concentration 2.1, unchanged from last year. Metformin therapy is discontinued. Which of the following is most effective measure to improve the patient's renal function? Okay, ready?
Okay. It is stop naproxen. Patients with CKD typically should avoid NSAIDs such as naproxen. These patients should discontinue naproxen because of an increased creatinine. Use of NSAIDs can precipitate acute AKI or progression of CKD. NSAIDs such as naproxen are inhibitor of COX, which has primary role in synthesis of prostaglandin and prostacyclin. These molecules modulate pain, sensation, and thermoregulation, maintain the gastric mucosal barrier, and regulate renal blood flow. If NSAIDs are use occur at higher dose with more potent agents over the course of a prolonged time. Acute CKD AKI can occur due to deficiency in prostaglandin that will otherwise promote maintenance of renal blood flow. AKI sustained in this manner, especially likely if high risk NSAIDs is accompanied by renal blood flow limited pre-renal insults such as volume depletion in the presence of nephrotoxins. In a patient with CKD, progression of disease can occur. NSAIDs are associated with renal papillary necrosis, which is sloughing necrosis of the renal papilla leading to gross hematuria and proteinuria. NSAIDs are also associated with AIN, which is caused by hypersensitivity reaction to medication like NSAIDs or anamide diuretics, and is characterized by rash, exothymia, steroid pyuria, hematuria, esophageal. Because of this, there are many negative associations with kidney. Avoiding NSAID is the best next step. Add furosemide will worsen renal function if used inappropriately. Furosemide is a loop diuretic that's indicated for management hypervolemic mistakes such as heart failure and cirrhosis. It acts in it acts at the kidney to promote fluid and electrolyte losses. However, directed therapy may result in hemodynamic significant hypovolemia that could worsen CKD. This patient has only trace edema and no other signs of hypervolemia. Okay. And thiazide medication regimen at thiazide could worsen renal function if used. Okay. Thiazide is a first-line treatment for management of hypertension. This patient blood pressure is normal with the use of lisinopril. Adding another antidepressant can cause hypotension, decrease renal blood flow, and worsen the kidney. Okay. Next.
Yes. 52-year-old woman who has 20-year history of type 2 diabetes mellitus comes to the physician because of one-day history of double vision and results when she closes either eye. She has no other symptoms. Her only medication is metformin. Vital signs are within normal. She is unable to abduct her left eye. Visual acuity 20 by 20. The remainder to know which of the following most likely lines. Ready?
Yeah. Mononeuropathy. Diabetic mononeuropathy of the abducens nerve is complication of diabetes that affect abduction of the eye. Abduction. The underlying mechanism of diabetic mononeuropathy is thought to be related to microvascular complication of diabetes, particularly the small vessels supplying the nerve, leading to ischemia and inflammation. This damage can lead to loss of function of the nerve, resulting in abducens nerve palsy. Patients will typically present with complaints of diplopia that improves with the closing of their eye. Diagnosis can be made by throughout physical exam, particularly of the eye movement, as well as imaging studies, such as CT and MRI. Treatment includes the use of glasses with prisms to correct double vision, and physical therapy to strengthen the lateral rectus musculature. In severe cases, surgical intervention may be required. Next.
Yes, a 57-year-old woman comes to the physician for evaluation of 2 weeks prior to an operation for varicose vein 2 months ago. She received 2 months ago. She received the diagnosis of the Graves' disease. For propylthiouracil therapy was began at the time. She has hypertension control with hydrochlorothiazide. She has seasonal rhinitis, takes over-the-counter decongestant as needed. She occasionally takes acetaminophen for headache. Her temperature is 37 degrees Celsius, pulse 76 per minute, respiration 20 per minute, blood pressure 130 per 82 examination of the lower extremity shows extensive varicose vein along the inner aspect of the left calf. Hematocrit 41, leukocyte count 1000, segmented neutrophil 25%, bands 2%, lymphocyte 59%, sodium 138, potassium 3.7, chloride 103, bicarbonate 24, blood urea nitrogen 16, creatinine 1. Which of the following is the most appropriate next step in the management? Ready?
Yeah. Stop PTU. Drug-induced neutropenia is an adverse effect of both PTU and metimazole. Treated used to treat hyperthyroidism. This patient received grave disease diagnosis 2 months ago and was started on PTU. PTU and metimazole inhibit thyroid peroxidase, while PTU also inhibits conversion of T3 to T4 to T3 by blocking 5-dehydrogenase. Rare adverse effect of this medication are granulocytosis, resulting in insufficient production of segmented neutrophil. This results in susceptibility to a variety of infection, increased risk for sepsis in the setting of neutropenic fever. Um, the treatment of for patients with drug-induced neutropenia is to stop the drug. Next.
4 years, sorry, 4 days after admission to the hospital because of abdominal pain and dehydration. A 52-year-old man with metastatic colon cancer is demanding additional medication to relieve his pain. On admission, treatment with IV crystalloid and acetaminophen was begun. On hospital day 2, his pain is increased in severity and he was switched to IV hydromorphone, which provided an adequate analgesia. This morning, in preparation for discharge, he was switched to oral hydromorphone at the same time. 8 hours later, he said the pain relief was inadequate, but the oral medication was maintained. Since then, he anxiously has been anticipating each dose of the oral hydromorphone by watching the clock. He has no history of substance use disorder. On mental status examination, he has an anxious mood and preoccupied with receiving pain medication. Which of the following is most likely explanation for this patient's adequate pain relief? Ready?
Sure. Low potency of oral hydromorphone. Opioid dose titration is necessary after beginning initial therapy and when switching from IV to oral dosing of the same agent. Of switching between opioid agent. By convention, the dose of an opioid is converted to its morphine equivalent dose, allowing for comparison of and conversion between opioids of different potencies. Hydromorphone is mu opioid agonist that's effective for moderate to severe cancer pain and is available in IV and oral dose formulations. Oral hydromorphone is approximately 4 times as potent as oral morphine, such that 7.5 milligrams of oral hydromorphone provides an equivalent dose to 30 milligrams of oral morphine. Oral hydromorphone is also less potent than IV hydromorphone and potentially in approximately 5 ml, 5 milligrams of oral hydromorphone should be given for each 1 milligram of IV hydromorphone when converting to from IV to oral dosing to provide an equinalgesic dose. Special caution should be used when switching between agents to cross tolerance, and it's common to start a new opiate agent at a reduced equinalgesic dose initially and then to titrate to dose upwards. Based on clinical response and tolerability, this patient has been transitioned from IV morphine, hydromorphone to oral at the same dose. Given the reduced potency of oral hydromorphone, he's likely experiencing inadequate analgesia and should have his dose of oral morphine adjusted correctly. It's not development of tolerance to hydromorphone. Um, is incorrect. Tolerance occurs as a result of chronic exposure of opioid receptors to opioid agonists, with resulting desensitization and downregulation of opioid receptors, such that an increased dose of opioid is necessary to achieve the same analgesic effect. Tolerance can occur quickly after even several weeks of opioid use. This previous opioid naive patient has been treated for only several days and is unlikely to have experienced tolerance. In addition, his dose of hydromorphos was not adjusted when switching from IV to oral. Okay. Increased dose, increased volume of distribution of hydromorphone is incorrect. Um, okay. Volume distribution describes the theoretical volume that would be necessary to contain the total dose of the drug at the concentration that is observed in plasma. Volume distribution is reflective of the degree to which the drug exits the plasma and diffuses throughout the other tissue compartments, depending on a variety of factors, including plasma protein binding, lipid solubility, drug, and blah, blah. While orally dosed opioids are subject to extensive first pass metabolism, this will reduce both the total amount of hydromorphone in the body as well as the drug plasma concentration, resulting in reduced bioavailability without altering the volume distribution. Okay.
Next.
Mm-hmm.
10 days after undergoing vaginoplasty and overseeing for a bleeding durinal ulcer, a 67-year-old man brought to the emergency department because of fever, difficulty breathing, and left shoulder pain. He was previously feeling well, tolerating of a new of normal diet. His only medication is oxycodone with acetaminophen. Temperature is 38.5, 101.3 degree Fahrenheit. Respiration 34 per minute. Blood pressure 140 by 85 millimeter. Mercury examination. Breath sounds are decreased over the lung base. Abdominal examination showed tenderness over the left upper quadrant. The incision site. The incision site is healing well. The remainder of the examination showed normality. Right stretches show raised hemidiaphragm. Which of the following is the most likely cause? Mm, Ready?
One moment. Schizophrenic access. Hmm, It's nerve injury. He has vagus nerve. From left lobar cholesterol injury.
Ready?
Yeah, ready. It is sophrenic abscess. Postoperative complication can include infection, bleeding, wound dehiscence, thromboembolic disease. Common cause of postoperative fever, atelectasis, pneumonia, UTI, infections of the cervical side, intrathoracic and intra-abdominal infection related to surgery. Thromboembolic disease with DVT or PE can also present with fever, and bacteremia can also cause fever. In this patient, the most likely cause of fever is intra-abdominal sophrenic abscess, abdominal tenderness in the left upper quadrant, and pain referred to the left shoulder. Okay. Infection or inflammation to the diaphragm commonly presents as referred pain to the shoulder. Diagnose to diagnose intra-abdominal abscess, CT scan of the abdomen with contrast should be done. Typically, the right hemidiaphragm is more elevated than the left hemidiaphragm because of the presence of the liver in the right. Okay. A raised left hemidiaphragm increases concern for a mass hematoma abscess in the left quadrant. Management involves IV antibiotics and in some cases percutaneous or operative drainage. Next.
A 65-year-old man comes to the office for a routine examination. He sustained a television myocardial infarction 1 year ago with subsequent revascularization and stent placement. The patient says he has felt well since his coronary procedure, and he reports no exercise, intolerance, chest pain, shortness of breath, no other symptoms. He has coronary artery disease, hypertension, hyperlipidemia. Medications are clopidogrel, lisinopril, metoprolol, atorvastatin. The patient smoked one pack of cigarettes daily for 45 years, but quit after his myocardial infarction. He drinks one glass. He drinks one glass of 104 kg. BMI 32 kg per meter square. Vital signs are normal. Physical examination disclosed no abnormality. Repeat ECG is unchanged from his last ECG. Which of the following is the most appropriate study for disease surveillance?
Ready?
Yes.
Is no additional studies indicated. Common risk factors for coronary artery disease include age, tobacco, diabetes, hyperlipidemia, hypertension. If significant coronary stenosis is present, patient may begin to experience symptoms such as angina, dyspnea, lightheadedness, dizziness with exception. In patients with clinically significant stenosis lesions, coronary stenting may be performed. And often results in significant improvement in symptoms. Patients with stents are often required to be on dual antiplatelet therapy, and compliance with this medication can lead to non-compliance can lead to complications such as stent thrombosis. What is he taking? Metoprolol. He's not copied over. Okay. There is currently no recommendation for routine surveillance in patients with coronary disease who have received intervention and are asymptomatic. Patients with coronary disease should focus on risk factor or defense such as stop smoking, exercise, management of chronic conditions such as diabetes and hypertension. Cardiac, no, it wasn't cardiac. Echo can be used to evaluate a cardiac function and to look for wall motion abnormalities in patients with ischemic heart disease. Most patients with coronary disease receive an echo at the time of diagnosis to obtain a baseline cardiac function, but this test is not indicated for surveillance. Radionuclear myocardial perfusion imaging compares myocardial perfusion at rest and during exercise is indicated in an outpatient workup of angina, as well as assessment of myocardial viability for patients who have suffered an ischemic injury to guide revascularization management decision. Okay, this patient is currently asymptomatic and no needs management. Next.
Okay, a 57-year-old woman, a 57-year-old woman with unresectable pancreatic cancer is admitted to the hospital because of 3-month history of constant severe abdominal pain that relates to the back. The patient has not decreased, sorry, the pain has not decreased despite an 8-week course of palliative chemotherapy and radiation therapy and treatment with transdermal fentanyl and oral oxycodone every 6 hours for breakthrough pain. She rates the pain as she rates the pain as an 8 on a 10-point scale. She says that the pain limits her daily activities and forces her to remain bedridden for 10 to 12 hours daily. She is able to eat occasional nausea, examined mild 6 centimeter mass palpated. CT scan abdomen shows which of the following is the most appropriate next step. What actually done for pancreatic cancer? Should we do? Okay,
Ready?
yes.
Celiac plexus blockade. Pain caused by cancer is associated with significant limitation in functional status and quality. The World Health Organization analgesic ladder to guide escalating pain management strategy in cancer patients. Initial management, non-opioid and adjuvant therapy, followed by addition of opioid for more severe. Opioid dosage often needs to be increased due to progression of metastatic disease, as well as development of opioid tolerance. Cancer patients often experience pain that is refractory to opioid. The final step with analgesic that involves invasive or minimally invasive procedure to achieve analgesia such as nerve block, ablative procedures, or intrathecal or epidural analgesia. Celiac plexus blockade is an effective minimally invasive pain management approach for patients with pain caused by pancreatic cancer that is refractory to high dose opioids. The celiac plexus is located within the retroperitoneal space on the anterolateral surface of the aorta near the origin of the celiac trunk. It provides autonomic and nociceptive innervation to the liver, gallbladder, stomach, pancreas, spleen, small bowel, proximal large bowel, and kidneys. The blockade is performed by injection of alcohol on the fluoroscopic area, resulting in neurolysis and effective pain control in most cases. Dorsal rhizotomy is incorrect. Dorsal rhizotomy is a surgical procedure that involves selective destruction of dorsal spinal rootlets in the lumbar and sacral region. It's useful for reducing spasticity in patients with cerebral palsy and other causes of spastic dysplasia. It plays no role in anesthesia. Intercostal nerve block is incorrect. Intercostal nerve block is useful for pain management in patients with pain affecting the ribs and chest wall. This pain occurs following cardiothoracic surgery or mastectomy or in the setting of rib fractures. The intercostal nerve does not provide sensory or nociceptive intervention to the visceral organ. Okay. Hello?
Yes, yes.
Okay.
A 67-year-old man comes to the physician for a routine examination. He has CLL, currently takes no medication. He feels well. Temperature normal, pulse 84, respiration 16 per hour, blood pressure 136. 72 examination shows a very small, firm, non-tender lymph node in the axilla. In the neck and the axilla, abdominal examination shows mild splenic hemoglobin 30, leukocyte 84,000, lymphocyte 60,000, platelet 1,49,000. The patient has greatest risk of which of the following?
Blast crisis, high lymphocytic CLL, this infection.
Ready?
Yep, it is infection. CLL is a malignancy of mature B lymphocytes. These abnormal cells can accumulate in the blood, lymph nodes, and other organs, leading to a variety of symptoms such as fatigue, weakness, enlarged lymph nodes. A recurrent infection, CLL is the most common type of leukemia in adults and is more common in people over 60. The exact cause of here is unknown, but several factors such as genetic mutation, exposure to radiation, and certain infections have been linked to development. In terms of complication, infection is the most common complication associated with CLL. This is because CLS can weaken the immune system, making patients more susceptible to infections. Infections can cause a range of symptoms from mild to severe and can be life-threatening, some depending on the organ that's involved and the presence of additional comorbidities. Not blast crisis is not commonly seen in CLL. While it's possible for CLL to transform into AL, acute leukemia, this is rare. Acute leukemias are more likely to undergo blast crisis, making, yeah. And then hyperviscosity syndrome can be seen in patients with CLL, particularly if their lymphocyte count is high. Increased viscosity of the blood can lead to symptoms of headache, dizziness, blurred vision, and in severe cases, seizure and stroke. Infection is more likely in patients with CLL. Okay. Okay.
Like, can you explain this? Like, we have to remember this
Yeah, I think you just have to remember this. Like CLL, so complication of CLS is infection.
infection.
Mhm.
Okay,
Okay.
let's stop for today.